Okay, it's recording now. Right. Okay, so the MRI scan shows a enhanced T1 weighted image. It shows a cystic lesion in left cerebellar hemisphere, approximately 1 cm in diameter with limited edema and little mass effect on the fourth ventricle. Although not shown on this image, there was evidence of hydrocephalus. There was no evidence of hydrocephalus. The sagittal view of a contrast enhanced T1 MRI scan. Sorry, sagittal view shows a cystic cerebellar lesion with a densely and uniformly enhancing nodule. The cyst wall does not enhance. So additional sequence that would have been important here includes a T2 image, often revealing fluvoids, which may be helpful to differentiate hemangioblastomas from pilocytic astrocytomas, of course. An important additional investigation study is a vertebral DSA, which may show a richly vascularized nodule and feeding vessels suggestive of a hemangioblastoma. Yeah. So what's your initial management? So for this patient, patient to be further assessed. So for a patient who presents with a lesion in the cerebellum that has a mural nodule, so one has to further assess this patient. Examination is important here because you want to know if the patient has cerebellar signs. And if there are any significant findings that may suggest movement problems. So we want to assess for coordination and all that. So first things first. Of course, this lesion is a P fossa lesion located on the cerebellar hemisphere. So the differential diagnosis of cerebellar lesions include that of P fossa lesions generally, which are located away from the midline. Of course, astrocytomas, hemangioblastomas, commonest. Then the midline lesions, of course, we know we have ependymomas, and more importantly, in children, you have medulloblastoma. And there are other differentials, though. Metastasis is a common differential there too, and gliomas and various other lesions that can occur in other parts of the brain that can also occur here. Meningiomas can also occur here. CP angle lesions can occur. So essentially, but the most important here are those initial four we mentioned. So differential diagnosis, one has to assess for cerebellar signs here because, and it wasn't mentioned in the case history, so has to assess for cerebellar signs, titubation, intention, tremors, pass pointing, dysdiadokinesia, Hilshin, lots of Hilshin coordination, falling to one side, ataxia, and all that. So it's also all important to ask for those things, nystagmus and all that. They're important in patients like this. Then giving so the initial management. So initial management in this patient, of course, admitting the patient and monitoring the patient. And I'll just hear the patient, so because the patient presented with headache, nausea and vomiting, and otherwise neurologically intact. So headache, nausea, and vomiting, one has to determine the cause of the headache. Is the patient having hydrocephalus? What's causing this raised ICP? Of course, we now know what's causing the raised ICP, posterior fossa lesion. And that's why it's having features of raised ICP. Although from their images, they said the patient does not have hydrocephalus. But the huge cystic lesion in the P fossa can also be a cause. So admit the patient, give analgesia, fluids resuscitation, he needs that. Then commencement of course, dexamethasone, that's steroids, can be important. If you look at the axial cord here, there appears to be some hypointense area around the cyst, which may be an indication of edema around it, even though it's not so significant. So one may give steroids here. Initial blood workup as investigations, complete blood count, electrolyte, coagulation profile, grouping and cross-matching. And then here they're talking about preparing the patients for, because of this edema and then the cystic lesion, if it progresses, patient may develop hydrocephalus and then may require either a shunt or an external ventricular drain. Majority of the surgeons will just place an external ventricular drain, then decompress the P fossa to re-establish CSF flow. Some people, if they want to do two-stage procedures, especially when the patient is not very stable, they'll start with a shunt and then subsequently go in and do the resection of the lesion. So whatever it is, so CSF diversion is important. Some may even go ahead and do an ETV for the patients. And then, so for CSF diversion, and it's important to note that if one is shunting the patient, he has to use, and you're using a programmable shunt, you have to drain the patient gradually, because over drainage can result in development of upward herniation, which may be considering the compression is from the posterior fossa, so there's risk of upward herniation in patients. So one wants to avoid that while doing CSF diversion. So that's another important thing to note. Yeah. Okay. Do I have anything to say? Any contributions on this before we proceed?
No. Till now it's going best. Only I want to discuss about that additional sequences. That I just wanted to clarify from my side. I'm just thinking that basically the flow voids we can see on T2 weighted images, correct? So on T2 weighted images, the flow voids look like the hypo intense signals. So basically this the lesion which is having mural nodule and cystic component, basically the most probable two diagnoses will be pilocytic astrocytoma and hemangioblastoma. So in hemangioblastoma, obviously it's a vascular lesion. So in that one, you will see on T2 weighted image, you will see more flow voids. And if you are going for the DSA, in DSA also you will see the richly vascularized nodule and feeding vessels. So on this basis, we can differentiate between these two. The other things, the everything, and you already told all of the sign mostly from the cerebellar examination from top till down. We can go like you told, from the eye we will start with the nystagmus and truncal ataxia, then slurred speech, then dysdiatokinesia, then all these things, same stuff. Yes.
All right, that's great.
Hello.
Very great.
Yeah.
Yeah, go ahead, please.
Yes. Maybe also something to add about the management of the hydrocephalus in this setting is most of the surgeons want to put the EVD in theater, not before they go to theater. Like after positioning, put the EVD, they clamp, then resect the tumor, and then they continue with it post-op as we monitor for hydrocephalus. If the hydrocephalus persists and it's a high output, then they can go ahead and convert it to a shunt. If the CSF output is low, then they can just take out the EVD.
Yes.
Yeah, another small thing.
You're right. Particularly in patients who are having, so there are two things here. Depends on the presentation of the patient. So if the patient presents with classical features of raised ICP with presence of hydrocephalus, so you have the option of pre-operatively decompressing the patient by placing a ventricular drain because of the hydrocephalus and all that. So, however, there's also possibility of development of then, however, you can also put an EVD on table. The reason why they place that EVD on table for patients who are having PFOA surgery is because of one, during your procedure, you may enter into the ventricular system, and then the patient may bleed into maybe the fourth ventricle, and that will result in and that may result in development of subsequent hydrocephalus. So that's one. So that's why they place that prophylactic EVD to drain to help drain the CSF pathway. If there's any blood within, it comes out and all that. So that's one. Two, another indication for placement of the drain is possibility of development of postoperative edema from your surgery, and that can cause raised ICP. So when they place that, it's to prevent is a prophylactic external ventricular drain, either for presence of blood in the CSF space to allow it clear, and two, to also prevent development of postoperative raised ICP and allow for possibility of managing it. So those are the options.
Is there a role of ETV?
Yes. So yeah, there's the role for external endoscopic third ventriculostomy. That's when and even shunting. I don't know if there's any further questions or contribution.
Another small contribution.
Yes, please.
On the investigations, I think the purpose they are doing at CBC here is to see the blood cell line, because if it is hemangioblastoma, we have a picture of polycythemia, and it is very important. They always speak it out in exam that CBC will show polycythemia, so we shouldn't forget that in our investigation. It's among the future of hemangioblastoma.
One more thing I wanted to ask, that when we are doing the posterior fossa surgery, mostly whenever we are putting EVD, it depends. We can use the other points. We have basic 4 points that also we already discussed, na? The Kocher's point, Keen's point, Frazier's point, and Dendy point. But mostly when we are doing posterior fossa surgery, so the EVD which we are placing, it's mostly for the Frazier's points. Because I think in the Frazier point, we is going directly to the occipital horn of the lateral ventricle.
Yeah.
Exactly. And we are just avoiding the Dendy's point, because in the Dendy's, there is difference between Frazier's and Dendy's point. See, Frazier's points from the inion, as much as I remember, from the inion, it's 6 centimeter above and 3 laterally. And in the Dendy's point, it's 3 and 3. So mostly we are using the Frazier's point and not the Dendy's, because the Dendy's is the one which is going to the, I think that occipital horn area, 18, 19, that area. So the patient will have blindness. So mostly we are using the Frazier's point.
Yeah, for PFOS approach, yes.
And that one is also easy to remember. Keen's point 3 from the pinna, 3 above, 3 medially. That is Keen's. And the last one, Kocher's point, we all know, from the nasion 11, and from the midline, it's around 3. and 1 centimeter in front of the coronal suture. From the mid pupillary line, you can also mark. So these are the basic 4 points. We need to remember the position of these 4 points. Okay.
Yeah. Very great. So very, very good contributions. Yeah, someone else wants to talk?
Yeah.
Okay, great. So let's just proceed. All right. So
yes.
So give your differential diagnosis of cerebellar lesions and which is most likely. So of course, I already talked about the differential diagnosis of cerebellar lesions. So midline cerebellar lesions, most likely either ependymoma or medulloblastoma. If it is cortical lesions of the cerebellum, it could be an astrocytoma or a hemangioblastoma. Those are the 4 main common differentials. However, there are various other differentials. Can be a metastatic lesion to the posterior fossa, can be a glioma, either low-grade or high-grade glioma. It could be a cavernoma, as a P fossa cavernoma. It could be other vascular lesions, AVMs, and all that. It could also be infections. Abscess, P fossa abscess can be there. It can be cysticercosis and various other lesions. So it's not just, but the commonest are the 4 mentioned. So let's see what they have to say. So here, differentials, they said hemangioblastoma most likely, METS, medulloblastoma, craniocytic astrocytoma, less likely abscess, glioblastoma, brainstem glioma, cavernous angioma, cerebellar liponeurocytoma, hemorrhage, or infarct. In the scenario where the tumor extends or originates from the 4th ventricle, not seen in this case, consider the following lesions: ependymoma, subependymoma, and choroid plexus papilloma. So the next question: how commonly are hemangioblastomas associated with VHL? We provide diagnostic criteria for VHL disease. So they said in 25 to 40% of cases, hemangioblastomas are found concomitantly with VHL. And then the diagnostic criteria is that of both the genetic variations and clinical manifestations. So the clinical manifestations includes an endolymphatic sac tumor, renal cell carcinoma, pheochromocytoma, paraganglionoma, glomus tumor, neuroendocrine neoplasms, and multiple pancreatic cysts. VHL is established in a patient with more than two or two CNS hemangioblastomas, or more than one CNS hemangioblastoma and one of the clinical manifestations described above, or more than one of the manifestations described above, and a heterozygous germline pathogenic variant of VHL gene on chromosome 3p25, 26, or a first-degree relative with an established diagnosis of VHL. So even if the patient does not have a CNS tumor, we can diagnose von Hippel-Lindau disease if the patient has either an endolymphatic sac tumor, renal cell carcinoma, pheochromocytoma, paraganglionoma, a glomus tumor, a neuroendocrine neoplasm, multiple pancreatic cysts. So either of those ones, if he has it, and then he has a first-degree relative that has established diagnosis of VHL, or patient has a gene test assay shows that the patient has a heterozygous germline pathogenic variant of VHL gene on chromosome 3p25, 26. Or if the patient has a CNS tumor and any of the aforementioned lesions, or the patient has 2 CNS hemangioblastomas. So essentially, that's the diagnostic criteria. Name other VHL-related lesions, their estimated age of onset, and their frequency. Here, so this is so we have CNS lesions and we have visceral lesions. Because CNS lesions, patient can have retinal hemangioblastoma, and the age of onset is usually around age 25 to 37 years of age. Frequency in VHL patients is 15 to 73%. Now, it's important to note this actually because some of these patients, according to Greenberg, patients may develop retinal hemorrhages. Those with that stuff. I think this table is actually from Greenberg. They may have retinal hemorrhages. Yeah, those with retinal hemangioblastoma. So retinal hemangioblastoma occur in greater than 50% of one Hippel Lindau patients, and the mean age of presentation is 25 years. It's frequently bilateral, multifocal, and recurrent. It's often asymptomatic, and usually symptoms occur with progressive growth, edema, retinal detachments, and hard exudates. It's typically located in the periphery and near or on the optic disc. Microangioma may measure about a few hundred microns without dilated feeding vessels and may be located in the periphery. Retrobulbar hemangioblastomas are rare, seen in 5.3%, and the severity of the optic disease correlates with CNS and renal involvement. Early diagnosis and treatment with laser photocoagulation and cryotherapy can help prevent visual loss. And then if it is refractory, low-dose external beam radiation therapy can be done for retinal hemangioblastomas. Okay, so that's one. That's for retinal hemangioblastoma. Then the other one is an endolymphatic sac tumor. That's seen at the age of 22 to 40 years. And it's not common, a frequency of 3 to 16%. The endolymphatic sac is supposed to be a cul-de-sac in the petrous portion of the temporal bone in the middle fossa that is just deep to the dura that communicates with the saccule of the inner ear. So the tumor is a locally invasive benign tumor that occurs in 10 to 15%. Okay. And 30% of these patients will usually develop bilateral endolymphatic sac tumors. That's for patients with von Hippel-Lindau. Only about 10 to 15% of them, 30% of them have bilateral ESLT. And it is only in VHL that you see bilateral ESLT. So if a patient, ELST. So if a patient presents with bilateral ELST, that's endolymphatic sac tumor, it's likely you should screen the patient for VHL. The ELSTs rarely metastasize, and it presents with hearing loss in 95% of cases and may be acute in 86% or insidious in 14%. There's associated tinnitus, vertigo, oral fullness, and facial paresthesias. And the mean age of onset of hearing loss is 22 years, as we mentioned earlier. So 22 to 40 years of age. All right, so the next one is cerebellar hemangioblastoma, which is what this patient has. And it's seen in 35 to 79% of patients with VHL, according to this chart. And the mean age is 29 to 30 years of age. The cysts are commonly associated with cerebellar. Cysts are commonly associated with cerebellar, brainstem, and spinal hemangioblastomas. And an important thing to note is that the mean age of onset for patients with VHL with cerebellar hemangioblastoma is 10 years younger than that of sporadic ones. So of course, means that the age for Sporadic is usually between 30 to 40 years, while that of cerebellar is 29 to 30 years. All right, so cysts grow, and the cysts grow at a faster rate than hemangioblastomas, than regular hemangioblastomas, and symptoms are often related to the mass effect, secondary to the cysts. Cerebellar hemangioblastomas were located in the superficial, posterior, and superior half of the cerebellar hemisphere. And 93% of the cerebellar hemangioblastomas in this located in the cerebellum and 7% in the vermis. So majority of the lesions are located on the hemispheres, and only 7% are located in the vermis, as in the midline. The hemangioblastomas are more frequently found in the superficial posterior half of the brainstem than the spinal cord. Hemangioblastomas have multiple sequential growth and quiescent phases. Okay. So essentially, I'm just like correlating Greenberg with the information here so that we can have a well-rounded understanding of discussion. So here the information is, so I've just finished talking about cerebellar hemangioblastomas. Majority of the cerebellar hemangioblastomas, as I said earlier, are located on the hemispheres, and they occur 10 years younger than the sporadic types. So that's the major take home from here. And they are usually associated with cysts, which are rapidly growing compared to the regular hemangioblastomas that are sporadic. The other is brainstem hemangioblastomas, seen in the mean age of 25 to 38 years of age, with a frequency of 4 to 22, so it's less frequent compared to the cerebellar type. And they are usually located in the posterior medulla, around the obex and the region within the area postrema. So if this is the case, that means the patients usually present with a lot of vomiting, right? So I don't know if anybody has any, let's just break it a bit. Anyone has any contributions for now before I proceed? Contributions, questions?
Nana, you did very nicely. You just correlated with all that from the Greenberg. There is one page, because when you are reading, I was just remembering that page. You are just reading from there all these. Basically, it's easy. See, we just need to remember the CNS lesion and the Whistler region. The CNS one, all the hemangioblastoma, basically it's involving which regions, like retina, cerebellum. In the front is brainstem, then spine, then supratentorial, and only the endolymphatic sac tumor. And from the visceral regions, they are just telling here, if you'll just read here also, and there you just need to remember the organs like renal, pheochromocytoma, pancreatic, all these stuff. So it's easy, but there is one more chart in Greenberg. In that it says, when we will just go further, it will say that how we will go for the annual. That chart is also very important in the last page. When you'll just reach there, just take the screenshot and just put it here. So it will be easy. Whatever you are reading now from Greenberg, just the screenshot, just send it here. It will be easy.
Oh, okay, so no problem. That's for you guys.
Because when we will reach there, there is like how you will go for the patient, like 6 monthly you will assess, or yearly you will assess. That last chart is also very important. It's given there.
All right, no problem. That's for the surveillance, right? Okay, so I think
yes, surveillance.
Okay, so the next is supratentorial. Spinal is 33 to 34. I think I'll just send a screenshot of this page to the WhatsApp group so that Or I'll just snap it because I have the hard copy of Greenberg actually. So I'll just snap and send to the WhatsApp page. So I've sent it to the page. I don't know if you can all see it there. So it's easy to follow. So I think yeah, so I think it's easier. I'll just read it up from there. The features. It's important to know all this, especially as regards to VHL. Okay, so these are the visceral lesions. So I think we just proceed. So the next thing is describe some tumors. Okay, they mentioned here also that additional tumors have been associated with VHL, including correct plexus papillomas, pancreatic adenomas, and adenocarcinomas, hepatic cysts, and more commonly, renal angiomyolipomas. They are also seen in VHL patients. Describe the basic principle of VHL transmission and tumor development, and who should be genetically screened. So it said that VHL is transmitted in an autosomal dominant fashion, and it's incomplete penetrance. It follows the two-hit model of hereditary cancers, requiring a second hit as a hit on both alleles and loss of heterozygosity in order to be able to cause tumor formation. And indications for genetic screening is a matter of debate, and nevertheless, genetic screening should be considered in patients with non-VHL-associated lesions, particularly at a young age, less than 30 years, or when an individual has a first-degree relative with a genetic diagnosis of VHL. Yeah. So preoperative evaluation of hemangioblastoma. Sorry. Preoperative evaluation includes craniosspinal MRI. Of course, when you see one hemangioblastoma, you have to screen for others. So because a patient can have a concomitant lesion in other parts of the body, in other parts of the CNS. So one has to do craniosspinal MRI. That's complete spinal MRI and brain MRI. Okay. So ophthalmologic and audiologic assessments, of course, based on the tumors that we know are associated with VHL. One has to assess the eye for retinal hemangioblastomas, and then also assess the ears based on the possibility of an endolymphatic sac tumor. And then abdominal CT to assess for the visceral lesions. It's also important. Laboratory work to look for presence of polycythemia, which can be seen in patients with hemangioblastomas, or renal cell carcinoma too. 24-hour urine, vanilla mandelic acid, homovanillic acid, and catecholamine acid. Catecholamine acid, of course, for patients with pheochromocytomas, and all this essentially for patients with pheochromocytomas. And then cerebral angiography and embolization for solid, highly enhanced nodules to decrease bleeding. Yeah. Then treatment options. Cerebral, not just cerebral angiography, even the spine, because you may need to do the DSA to assess for the feeder vessels if one has to, if there's a spinal hemangioblastoma, sorry, for you to be able to do preoperative planning or even just embolize it. So what are the treatment options? Surgery. The aim of surgical treatment remains complete removal of the hemangioblastoma. However, multiplicity of lesions and their frequent proximity to vital structures can preclude complete excision. Only symptomatic lesions should be operated, while small asymptomatic lesions can be followed with careful surveillance. Surgery is the best option for single accessible lesions. Resection of cerebellar hemangioblastomas leads to symptomatic improvement in up to 98% and absence of recurrence in up to 100% of cases. So, surgical technique for this case can be a suboccipital midline incision and suboccipital craniotomy, intraoperative ultrasound scan to localize the hypoechoic cyst, a wide-shaped dural opening, cervicospinal CSF drainage via the cisterna magna, so in order to allow for brain relaxation, aspiration of cystic content, extranodular dissection and coagulation of feeding and draining vessels, and then M block removal of the nodule. So those are the stages for this surgery, and then excision of the cyst wall is not. They said it's not necessary. If you remove the mural nodule, that's okay, because the cyst wall usually does not contain tumor. Careful closure to avoid CSF fistulas and to allow easier reopening in cases of recurrence, especially in patients who have VHL. Then the next is radiosurgery for hemangioblastomas, which should be considered for patients with multiple hemangioblastomas or surgically inaccessible lesions. Different modalities can be used, including SRS, EBRT, and proton beam radiotherapy. SRS is generally given in a single dose of 1,800 to 2,000 centigrades. And SRS controls majority of primary and recurrent hemangioblastomas less than 3 cm in size. Response to SRS is enhanced in non-cystic hemangioblastomas, and local control is estimated at 82 to 94% at 5 years following treatment. However, in cystic tumors, radiosurgery does not reduce the cyst size, and additional removal or repeated evacuations of the cyst may be necessary. One may give angiogenic medications like fibroblast growth receptor inhibitors, which may constitute an option of hemangioblastomas that are not amenable to surgery or radiosurgery. All right. So the next is describe your post-operative follow-up. So hemangioblastomas are slow-growing tumors, but there's a risk of the tumors themselves are slow-growing, but the cysts can rapidly enlarge, as we discussed earlier. And then there's a striking tendency for multiple occurrence, especially in VHL patients. So, and then pregnancy can be accompanied by a rapid enlargement of the cyst within a few months, and sometimes leading to dramatic complications for both mother and fetus. So regular surveillance is important, which includes periodic enhanced MRI scans, abdominal CT, ultrasound scan, urinary catecholamines, ophthalmologic and audiologic evaluations for both early diagnosis and follow-up of different manifestations. Rising hematocrit level may suggest progression or recurrence. Periodicity of specific examination depends on age, the number and types of manifestations in each patient. However, generally, MRI is repeated every 6 months in presence of lesions and yearly later if stable. Spinal, okay, so there's a spinal MRI above that here, this one. We already described it earlier. So it's this is a sagittal cut that shows rounded, avidly contrast enhancing lesion at the level of T5 vertebra, actually, according to that, junction of T5 to 6 vertebra. Okay. So the question on it is, describe your management. How will you manage that? So So surgery is the mainstay of treatment here. And as we discussed earlier, before you operate, you have to have imaging, an angiogram at least, to be able to help you identify the feeding vessels. You can actually embolize if you can, and then you can also use intraoperative dyes like ICG dyes, as indocyanine green, which can help you identify the feeding vessels so that you can attenuate them before you now do your excision. That would help reduce the risk of bleeding intraoperatively. The lesion has well-defined margins, so excision is can often give you a cure in this case. And it's following complete resection. Recurrence is rare, and neurological deficits are usually transient and not very pronounced, especially when resection is careful. So, use of minimally invasive spine surgery can be done in this case. Overall, symptomatic improvement occurs in 2/3 of patients with sporadic hemangioblastoma. Okay, so that's the end of the discussion here. There are also some information from Greenberg that I want us to look at. They described some of the treatment plan and talked about, here they talked the one like here where they talked about a single dose SRS. Greenberg mentioned some form of SRT. So they talk about a treatment plan using a median dose of 22 gray, a range of 12 to 40 gray, prescribed to median ectopia incidence in 1 to 4 sessions. So you can give it up to 4 sessions. And then the treatment should be concentrated on the mural nodule. It's actually not, can ignore the cyst and just focus on the nodule. And then spinal treatment plan. For a treatment plan, they use 21 gray, in the range of 20 to 25 gray, and prescribed to the median 77% ISO dose line. And this one is usually given 1 to 3 sessions, unlike the cranial that is given 1 to 4 sessions. Yeah, they just mentioned that radiosurgery is usually contraindicated in hemangioblastomas with a cyst. I don't think it is contraindicated though. I think it's just that you just focus on the mural nodule and then you can aspirate the cyst. All right, so surveillance. Because of the lifetime risk of developing tumors, regular surveillance is needed. Various protocols have been proposed. The algorithm by the VHL family outlines for patients with VHL and at-risk relatives is shown in table 441.6. Let's look for a table. I'll post that table. Yeah, so there's a table here in Greenberg. Any age, so they mentioned age, any age, DNA test for VHL marker is available to identify family members at risk. From conception, obstetrician should be informed of family history of VHL. From birth, check for neurologic disturbance. The patient has nystagmus, strabismus, white pupil, refer to retinologist for abnormal findings. So you want to rule out retinoblastoma or retinal hemangioblastoma, sorry. 1 to 4 years, annual retinal exam, especially if positive for VHL mutation. Pediatricians should check for neurologic disturbances. 5 to 15 years, annual physical examination, including orthostatic blood pressure measuring, examination for neurologic disturbance and other retinal problems. Tests for fractionated metanephrines, abdominal ultrasound scan starting at age 8 or earlier if indicated. Every 2 to 3 years, complete audiologic exam annually if the patient has hearing loss, tinnitus, or vertigo. Or the patient has repeated ear infection, one may want to do MRI with contrast to look for ELST, that's endolymphatic sinus tumor. And after greater than 6 years, monthly retinal 6-monthly retinal exam can be indicated. And then annually, you still have to do a retinal exam, do assess for the scrotum, physical examination, including scrotal exam in males, neurological exam, urine for metanephrines and catecholamine, abdominal MRI, or MIBG scan. Abdominal ultrasound scan can be done, and all that. So yearly exam, every 2 to 3 years, MRI should be done for the patient. Brain MRI should be done for the patient. 1.5 Tesla to look for hemangioblastomas in the P fossa, and then ESLT in the inner ear. Also MRI, so craniospinal MRI should be done for the patient every 2 to 3 years, and then a complete audiology exam. Prior to surgery or childbirth, the patient should have blood tests done and urine tests for metanephrine. So essentially, that's the plan for patients with VHL, and this is by the National Institute of Health, NIH. They are the ones that conducted a study on these patients. So I'll snap this page so that we can also look at it and familiarize ourselves with it. Dr. Ali, do you have any questions or anything to add?
Nana, the only one point I want to add is basically what happens. It's written like in SRS, suppose basically the SRS is not acting on the cystic lesion, it's just acting on the mural nodule, and cyst you need to aspirate. One more thing I just wanted to add, that's how we will know that basically, see, it's written that in this case, no need to remove the cyst because the cyst is not having the tumor cells. Basically, what happens when the cyst is having the tumor cells, so the wall of the cyst, it will also enhance. So in many books, it's written like that, suppose that if you're giving the contrast and after contrast enhancement, the cyst wall is also enhancing. So it shows that the cyst wall also contain tumor cells. Then you need to excise the wall of the cyst also. So in most of the questions in theoretical exam also, it's coming whether in the pilocytic astrocytoma cases also and hemangioblastoma cases also. If they're giving you that the tumor cyst wall is also enhancing, then your answer should be you need to excise the tumor cyst also. Means the cystic wall also. But if it's not enhancing, it means it's not containing the tumor cell. Then you can just leave it over there and just aspirate it. That is just the one point I wanted to add. The others, already you covered everything.
Thank you.
Maybe something also to add is it's important for us to do intraoperative neuromonitoring during the posterior fossa surgeries.
Yeah, so hello, Chief. You said what?
The importance of intra-op neuromonitoring.
Yes. Very, very important. Yes. For P fossa surgeries. Yes. Thank you very much. Right. Okay, so any other questions, contributions before we call it a day? It's 10:16 already. We started about 50 minutes ago. So.
No addition.
No, I think we have already covered a lot. The whole topic from here also, and most probably from the Greenberg also, we have covered it.
Yeah. Okay, all right. Thank you very much. The only additional thing from Greenberg is that the epidemiology of von Hippel-Lindau is 1 in 31 to 36,000 live births. Approximately 30% of patients with cerebellar hemangioblastomas have VHL. That's already said. There are 4 subtypes. Actually, there are 2 major subtypes of VHL, and then type 2 has 3 subgroups. So type 1, any manifestation of VHL, typically hemangioblastoma and renal cell carcinoma. Any manifestation of VHL except pheochromocytoma. That's type 1 VHL. Then type 2A, pheochromocytoma is characteristic and renal cell carcinoma is rare. In type 2B, patients have high-risk hemangioblastoma, renal cell carcinoma, and pheochromocytoma. And then type 2C, we have risk of pheochromocytoma only, without risk of hemangioblastoma or RCC. So those are the variants, or subtypes of VHL here. Okay, so that's essentially it. All of that thing has been discussed. So, okay, well, thank you very much. It's been an interesting discussion. Okay, right?
Yes.
Yeah.
Well,
Thank
good night,
you.
everyone. Yeah, thank you.
Yeah, thank you so much. Okay.
Are you going to send the recording?
Yeah, I will. I'll post the recording, of course. I recorded this one.
Yeah.
Yeah. Okay. Good night, guys.
Okay. Thank you. Good night.
Who is in the next case?
Yeah. So who's taking the next case? Can any of you take parasagittal meningioma? Dr. Ntege or Skasire? Sorry, apologies. How do I pronounce your name, Dr. Skasire? So I don't want
That's
to
the
pronounce it wrongly.
pronunciation. Kasirie.
Skasire. Oh, okay. All right.
Yes.
All right. Perfect. Okay, perfect. All right. Okay, so which of you wants to take it? Dr. Skasire or Dr. Ntege?
I'll take it.
Okay, so tomorrow, God willing. All right, so thank you very much. Thank you all.
Thank you.
Yeah.
Thank you. Good night.
Good night.